more, then we will start, sir.
Just a minute.
Yeah. So can we start, sir?
Yes.
Okay. First, I will give your introduction, and then I will hand over the session to you, sir.
Wow.
So in next 10 seconds, we will go live to the attendance, sir.
Yes, sir. Already maybe
Good evening and welcome all the dear delegates. Today we are going to discuss on a very important topic, which is role of semaglutide in MASH, evidence, evolution, and clinical impact. To present this topic, we have eminent speaker Dr. N. Arun sir. Sir is qualified as MD, DM in Gastro and currently working as Apollo Hospital in Chennai. So without taking much time, I would like to hand over session to you, sir. Sir, over to you.
Thank you. Thank you very much, Team Looping, to give me a wonderful opportunity. And dear friends, it's really great pleasure for me to be here to discuss one of the very interesting and fascinating area right now in the field of hepatology to tackle a patient with fatty liver disease. See, the fatty liver disease is a very characteristic and specific entity. It's a broad entity. So to categorize who are all the patient we need to bring into further evaluation, that's very, very important when you're going to look into the clinical scenario. The most important thing is what do you mean by fatty liver? In case if the liver hepatocytes, if it is going to be accumulate more than 5% of the fat deposition, which is going to get happen, which means the patient is going to land up with evidence of fatty liver. In your routine practice, even if you're a physician, or a surgeon or a gynaec, whatever the background, if you're going to have a routine ultrasound surveillance, you might be coming across with multiple patients with evidence of fatty liver, for example, grade 1, 2, 3, and 4. But once a patient is going to land up with this kind of fatty liver background, are we routinely screening in our Indian practice? It is definitely a questionable target because most of the patients and more even as our community with among doctors will not be giving much of importance to this problem of fatty liver. So why such scenario is very important? Because you all should remember that nowadays, when compared to the westernized population, when compared to Western population, even in Indian scenario, the rate of liver disorders with fatty liver will be more common as par with your alcohol-induced liver disease. And almost it's going to supervene your alcohol-induced liver disease soon. So what I'm supposed to say here is the fatty liver, it's a common metabolic liver problem. And initially we have been used to terminology what's called as non-alcoholic fatty liver disease. Now it has been completely been replaced with metabolic associated steatotic liver disease. Why such parameter has been taken over? Because it's a conglomeration of multiple parameters. This event is not going to set in only based upon the patient is going to, whether the patient is going to consume either alcohol or not alcohol, because there is an entity what is called as MET ALD. It's a metabolic associated liver in the background of alcohol-induced liver disease. It's nothing but your MET ALD is also a conglomeration of presentation will be there whenever you're going to look into this picture. So once the patient is going to land up with evidence of fatty liver, if you're not going to give a proper care, so there is high possibility for the patient to go into evidence what's called as MASH, metabolic associated steatohepatitis. What's going to happen in which the hepatocytes, if it is going to get ballooning, the degeneration and all the changes, the inflammatory cascade, if it is going to get happen, there is high possibility for the patient to land up with evidence of MASH. So the liver enzymes, the clinical picture, the scenario will tend to worsen and make the patient to hospitalize. And once the patient is going to not address this MASH scenario properly, there is high possibility for the patient to land up with evidence of fibrotic, followed by cirrhosis. And there is a high chances among 1 to 4% of the population in India with fatty liver were not going to treat adequately. There is a risk to progress for a dangerous, dreadful malignancy called hepatocellular carcinoma. So why such entities we need to give importance? So whether the patient is having metabolic syndrome, very simple. If the patient BMI, if it is tends to be more than 2.5, if the patient is having heart risk of overweight, or if the patient is obese in the background of BMI, if it is going to be more than 3.0, or if the patient is having evidence of hypertension, your dyslipidemia, your low HDL along with your TGL if it tends to be in the higher side, and your sister and your BP variation if it is which means in the background of your type 2 diabetes, there is high possibility for the patient to land up with evidence what's called as metabolic syndrome. Once a patient is going to take on with this metabolic syndrome, you should not forget very commonly the patient will have fatty liver. Why such things is very important? Because you should know obesity is a characteristic phenomena. Once a patient BMI, if it is going to be more than 2.5, if it is going to be in the range of 3.0, or supermorbid obese in case of the BMI, if it is going to be more than 4.0, which means the global prevalence of your metabolic liver disease will be in the higher side to that kind of population. So addressing obesity is a major challenge. And why such things is important? Because the patient, the mortality because of the liver disorder, it's not only because of the liver, the risk of mortality because of the major acute cardiac or coronary events, because of the cardiovascular events will be more common in the background of fatty liver. So once a patient is having morbid obesity, the patient, for example, if the patient BMI if it tends to be more than 3.0, the patient may have multiple catastrophic events or presentations, starting from respiratory distress, your tachypnea. The patient may have evidence of obstructive sleep apnea. The patient may have coexisting thyroid-related disorder. The patient may have gynec events like polycystic ovary. The patient may have psychosomatic depression and anxiety disorder. The patient may have cardiovascular events like a major acute coronary, or the patient may have major acute kidney-related events, or the patient may have neurological presentation like your hypertension-induced stroke and other manifestations. There are huge list of catastrophic events because of this fatty liver, obesity, metabolic syndrome. The patient may land up with further complications. So how are you going to address such scenario? So to prevent my area to talk on, in order to prevent the patient to go for evidence of the fibrotic changes of the liver to happen, to prevent that, what is the best line of treatment? For fatty liver, there is no single molecule being proven to be having a significant beneficial role, except evidence of vitamin E, and there is some papers of solaglitazole, and few molecules are being tried with resmetirom and other things. But what I would like to point out, once the patient is going to land up with evidence of steatohepatitis in the background of early fibrotic changes, which is going to get happen, so you need to address such scenario effectively. The diet, lifestyle modification, it's so important to address this kind of scenarios. So briefly about this wide introduction, you should go remember that the prevalence of NAFLD will be higher among the diabetic population, almost around 50 to 60%, or obese population almost around 60 to 90%. In the background of metabolic syndrome will be going almost around 70%. As you all know, all the major pointers have been already discussed. What is the natural semiology of events, which means already been discussed. Once a patient, the rule of 20 is going to get established. What is that? There is, once a patient is going to land up with evidence of fibrosis. What do you mean by fibrotic changes? So, for example, if the patient is having morbid obese, and if you're going to do a fibroscan assessment in which you're going to assess your fibrotic scoring system. So, for example, if the patient's steatotic parameter, if it is going to be more than 240, for example, the steatosis, if it is going to be more than 290, which means the S3 component of your fibroscan will be the higher side, or if the patient is, for example, the fibrotic parameter, which means the KPA value, if it tends to be more than 12, which means the patient is going to land up with evidence of cirrhotic changes. So why I would like to point out this picture, you should target the fibrotic marker should be less than 6, your KPA, and your fatty liver index should be less than 240, your steatotic marker. So in this fibroscan, there are various huge list of clinical assessment parameters, starting from your liver function, starting from your fibroscan assessment, and there are newer modalities like VCTE, vibration control transient elastography, or in which you can do, in this picture, we can see this is ELF scoring or APRI or NAFLD fibrotic, your FIB4 scoring, which means AST, ALT, platelet ratio, all these things, if it is going to see. So what are you going to look for this picture? The major thing is your ELF, which means three major components. One is your hyaluronic acid, your procollagen, and so this is all the major components you need to see. If the ELF, if it is tends to be more than 9.8, which means the patient, the fibrotic changes will be in the higher side. So this is what the basic point is. There are so many markers are there to look for evidence of the fibrotic change which is happening, which is out of discussion. You should remember that if the patient is having fatty liver, morbid obesity, metabolic syndrome, into whom you are going to subject the patient with your fibroscan assessment, your VCT, followed vibration control, transient elastography, in which we can able to identify whether the patient is having evidence of metabolic steatohepatitis with fibrotic changes is happening or not. So the rule of two, which means the bridging fibrosis, happens within a span of 2 years. The patient may have around risk of cirrhotic to get progress. And another 2 years, hepatic decompensation. As you all know, the patient may have GA bleed, varices, ascites, NCAF, all the major presentation in gastroenterology. The high possibility for the patient to have worsening of events, and the patient may succumb because of the liver failure. So why I would like to point out this picture, to recognize the patient immediately is very important. So there are non-invasive markers. Now your FibroScan, your FIB4 indexes, and your NAFLD fibrotic scoring, your APRA, which means your AST platelet ratio index, all these pointers you are going to see to look for whether the patient is having evidence of fibrotic changes which is happening in the liver. So with this, we can able to scrutinize the population to whom you are going to identify whether the patient is having risk to progress to cirrhotic changes, which is going to happen in the near future or not. And very importantly, this is what the vicious cycle: metabolic syndrome, obesity, type 2 diabetes, dyslipidemia, hypertension, all this major picture. If it is not going to treat your insulin resistance, if it is going to augment, followed by the patient will have worsening of lipid de novo lipogenesis, which is going to get activated, and obesity, which will be progressing to MASLD, MAS surge, mainly by insulin resistance and inflammation. And this is going to act as a vicious cycle pathway, which is further worsening, which will enhance the rate of progression of fibrosis and liver-related mortality and change over into hepatocellular cancer. So why I would like to point out this, there are certain few expert questions being discussed. The patient with obesity who are also having evidence of MASLD, overweight with normal weight, all this picture we can discuss. But very importantly, as I already pointed out, 50 to 60% and 60 to 85% normal weight. Now still 10 to 25% of the population, there is evidence for the patient to have progression of this kind of events to happen. So usually age spectrum, it can happen in pediatric population till the adult age group. In any age group of population, you may land with evidence of this fatty liver disorder. So you need to be very cautious to address this kind of presentation. So what is the routine screening problem in Indian scenario? If the patient is going to take alcohol for a duration of time, you can able to identify the picture easily. But in Indian scenario, recognizing fatty liver is a challenging task. So once a patient is going to have evidence of fatty liver, or we subject the patient to routine surveillance with your VCTE or your FibroScan parameters, and all those things is still not established well in major centers in India. So why? Because 90% of the people still remain undiagnosed with MASLD, 75% of the MASH population still remain undiagnosed, which will be predisposing to all the major catastrophic events like your type 2 diabetes, cardiometabolic risk factor, and all those things. So how do you going to align this clinical guidelines? For example, your ASLD, your ADA, all these real world guidelines. There are so many guidelines which has been quoted for this fatty liver. How are you going to recognize, when you're going to subject, when the patient deserves further workup, when the patient deserves transplant workup, what is the best line of treatment you're going to see. Various trials and various discussions being happening. But overall, the populated, who are the patients should be focused. First criteria, if the patient is having type 2 diabetes, there is a high possibility, because in the background of India as a diabetic capital, we need to address around 60 to 80% of the population in the background of type 2 diabetes, the risk of progression to MASLD in the higher side. if the patient is having morbid obesity, which means the BMI of it tends to be more than 30, which means you need to be cautious in the background of hypertension, in the background of thyroid-related disorders, in the background of PCOD, in the background of cardiovascular disorders, if the patient is having old age population. So all this high risk of frailty parameters you need to see to address this kind of patients. These are all the focus population. We should not miss this kind of scenarios to diagnose a patient with fatty liver disorders. So what should be the various screening modalities? As I discussed, basic liver function, your platelet ratio indices, and your AST-ALT ratio, along with your ultrasound clinical picture. Look for evidence of steatotic changes in the liver, which tends to be more than 30%. If it tends to be there, that means the patient is having worsening of your fatty liver changes. Or if the patient is having evidence of suspicion of MASH, you can subject the patient for liver biopsy to look for hepatocyte degeneration as well, ballooning of hepatocytes and inflammatory cascades and all those things. But nowadays, non-invasive markers, like already been discussed, your NAFLD scoring, along with your enhanced liver fibrotic scoring, your APRA indices, or your FIB-4 indices. These are all the indices in which we can try. You can able to identify with your VCT, with steatosis and fibrosis screening. So we can able to diagnose the patient in an earlier way, and we can able to counsel the patient for diet, lifestyle, with regular follow-up with the basic medications, what are the best things we are going to choose. And then we can able to improve the clinical scenario reasonably well. So regarding my opinion on the role and reliability of NATs for diagnosis, definitely the biopsy is not a significant pointer nowadays, because even in Essence trial, when you're going to use a semaglutide, but they've been used a biopsy-proven patient. But nowadays, the role of biopsy, it's not a major challenge to address fibrotic or early fatty liver disorders. So non-invasive markers itself has been taken over with a wide range of assessment to diagnose this fatty liver disease promptly. And do you see NIT as an important tool? Definitely, sure. It should be reached to all the primary care physicians. It should be reached to all the tertiary care centers, and it should be reached to all the peripheral centers throughout India in order to diagnose this kind of clinical scenario effectively. The historical background of briefly talking about this interesting molecule nowadays is very major area like a GLP-1 receptor agonist, nothing but your semaglutide. And the other one molecule, nothing but your tirzepatide, in which the dual agonist GLP and GIP. Now, even one more GLP, GIP, along with glucagon based agonist also being there, right? Like your retatrutide, all these molecules are there. But when you're going to use the best molecule, what's being considered as of now the proven things, or vitamin E at a rate of around 800 milligrams, you can consider in the management of your MASLD. Or you can consider resmetirom, has been given in various trials, 80 milligrams or 100 milligrams, depends upon the weight criteria. You need to choose your resmetirom, which is THR beta pathway, which is going to get involved in that. So based upon that, you can consider resmetirom. Or there are your list of molecules like a soraglitazide, which means your PPAR. In that kind of presentation, when you're going to use at a dose of around 4 milligrams, these are all the trials for lean NASH patients, in which lean NASH, the main problem is the patient may not be obese, but the liver enzymes tends to be deranged. The clinical picture will not be, and the hepatocyte inflammatory cascade, which is going to get happen, which means the patient is going for evidence of your lean NASH. So that kind of scenario, your GLP is still a questionable challenge to address, but there are some papers to look for the beneficial role with GLP-1 receptor agonists with even in the background of lean NASH, but we need more and more data to support that. The most important clinical picture as of now, well-approved molecule is your soraglitazole in the background of diabetic dyslipidemia and lean NASH. We can able to consider that. So why I would like to point out, these are all the major things. And liraglutide, which has been initially tried, we showed evidence of MASH resolution to almost around 30% of the population when compared to 9% the placebo group. But the fibrotic changes, the rate of improvement with liraglutide is not a major challenge to get addressed. And regarding this basic interesting molecule, what's called as semaglutide, in which we are going to see this is nothing but a GLP-1 receptor agonist, which predominantly located in your L cells of your GI tract. rather than completely augmenting, rather than being locating in your hepatocyte predominant area, it is being located in various other peripheral sites like your brain, your lungs, your heart, your pancreas, your kidney, your gastric mucus, and all these things, your L cells of your GI tract. And why this GLP-1 receptor agonist, which means your semaglutide being considered, is it is almost 94% in human structural moieties to be considered. It is going to have a usual common analog structure when compared to other molecules, and the TF almost will be going around approximately 1 week. And the main thing is the substitution of amino acids, which will be in the predominant pathway of 31A amino acids, which is going to get involved. And why? Which means the endogenous GLP, which is being will be having a limited resource, and the D due to T of will be in the lower side and high rate of susceptibility, and there will be evidence of gross degradation, which is mainly by your DPP4 products and all those things which is going to get involved. This is a basic your biochem if it is going to see the outline structure of your semaglutide. So basic mechanism of action, if you're going to see the patient, once you're going to give semaglutide at a dose of starting from 0.4, and if you're going to escalate 0.25, if you're going to escalate to 0.5, 0.75, and up to 2.4 milligrams, if you're going to titrate the dosage every 4 weekly, the most important mechanism, it mimics GLP-1 incretin hormone. So glucose dependent insulin secretion, suppress of glucagon, appetite regulation, and weight loss, inflammatory cascade, and fibrotic changes in the liver will be having a significant improvement. So if you are going to see the pathophysiological cascade of your fatty liver disorder, very importantly, you should not forget one is the most important thing is your insulin resistance. Once the insulin resistance is going to get augmented, so the lipid influx will be there, which means the patient will have more of free fatty acids will going to get released, oxidative stress if it is going to get happen, and the patient may have more of inflammatory markers, mitochondrial dysfunction, and gut dysbiosis, endoplasmy. So all these things. So very importantly, you should remember that hormones like your adipokines, which is going to go down, your leptin levels, if it is going to be high, your advanced glycation end products, if it is going to be augmented, and all the inflammatory markers like your NF-kappa and all those things, if it is going to be elevated, followed by the enzymatic cascade of NADPH oxidase, which is going to get activated. At this kind of potential, there is high possibility for the patient to have worsening of your fatty liver disorder. So what is the mechanism of this semaglutide? Targeting major pathways to lipolysis, early satiety, that's one which is going to prolong your gastric emptying time, and insulin secretion if it is going to hurt augmented, followed by the rate of glucagon and all those things which is going to get calmed down, and free fatty acid influx if it is going to get, and de novo lipogenesis will be inhibited, lipotoxicity is going to get prevented, and all the major inflammatory cascade of enzymes like your AMP, your chimeric protein, your steroid response element, all these things, the PPR oxidation, beta oxidation pathway is going to get augmented. The patient may have worsening of fibrotic changes, will have significant improvement, and inflammatory cascade will have significant improvement once the patient is going to have your semaglutide. So it be acting on neurologically, it be acting on your pancreas, insulin secretion, all those things, satiety, and improvement of prolongation of gastric emptying, and all those things will be having a de novo lipogenetic effect, lipotoxicity, fatty acid oxidation. So all this picture will be having a predominant direct role with your semaglutide. Thereby, the patient may have evidence to show that the patient clinical picture of fibrotic changes will be having significant response when you're going to use your semaglutide. And this is very interesting paper, Essence Trail. What they have been looking into that, when you are going to use this semaglutide, first for the initial phase of 72 weeks, followed by the prolongation of almost around 240 weeks of duration, to whom when you are going to consider starting from escalation of therapy 0.25, 0.51, 1.7, and maintaining at a rate of 2.4 milligrams once in a week if the patient is going to be maintained. So what they're going to see, the fibrosis will be improving with the worsening of MASH. the MASH will be improving without worsening of fibrosis. This is what the basic thing we should not forget. And all the major cascades. For example, what are the things you need to see in this essence trial? See, regarding semaglutide, various trials are there. Very interesting trials. What I would like to point out is one is this essence trial in whom we are going to consider in the background of obesity and in the background of MASLD, which means the patient, when you're going to subject for a duration of time, the patient non-invasive markers and enzymatic changes, ELF scoring in the background of fibrotic changes and cardiac events, all these things will be having a significant potential response. But cardiac events, rather than in this trial, they'll be looking for other trials like there are so many other trials to look for this semaglutide. For example, Pioneer as well as Soul based trials, they've been focusing on type 2 diabetes, and other trials like Sustain and Flow in the background of your type 2 diabetes and obesity, they can be able to identify that. And very important trials for metabolic dysfunction, liver disease is Essence trial, or you can consider STEP trials, or you can consider this select trials to whom you are going to look for evidence of major acute coronary events to get prevented. These are all the various trials you should remember. Whenever the postgraduates are being here, you should not forget these are all the trials which should be very important for our Vivavos and all those things. And so once the patient is going to subject with this kind of treatment, that is show the resolution of steatohepatitis with no major worsening of fibrosis. And the liver fibrosis is going to get improved without major worsening of steatohepatitis. This is what been proven in these people. And as already been discussed, ELF scoring, liver stiffness, all these major pointers will be having significant response with your semaglutide when compared to your placebo. So this is what I would like to address here. So your ELF scoring, I'm sorry. Your ELF scoring, liver stiffness, the change in body weight, the resolution of steatohepatitis, as well as fibrosis regression, and all this picture, you can able to show that the patient will be having significant response that shows the secondary endpoints have been significantly attained. So this is another paper based upon Samara, in whom if you are going to have a phase 3 randomized trial, even Essence is a phase 3 randomized. So when you're going to use this, the inclusion criteria of your BMI, your FAST, which means your focused AST scoring system, your LS and liver stiffness, if it is going to be more than 8, and all these criteria. So primary outcome, the change in your FAST scoring, along with the secondary outcomes, your MRI PDFF, which means your proton density fraction, along with the ALT, HbA1c. PDFF, you can take into account, which showed a significant pointer, but it's still in Indian scenario, it is very difficult to establish to most of the patients because the cost constraints and other things will be a challenging task to address. So in this paper, it showed that non-invasive tests can reliably identify the patient at risk of MASH who are eligible for treatment with semaglutide and can able to point out their treatment response too. So the fast reduction and MRI PDF of response, all these points should be addressed with your Samara. So this is what the questions which is being flowing here. Semaglutide be integrated into existing treatment algorithm. No doubt about that. This one been discussed. Once the patient is going for F2 to F3 fibrotic changes, which means the patient, the fibrotic markers, if it is tends to be the higher side, if the patient shows evidence of F2 to F3 in the background of obesity, metabolic syndrome, it's better to add on the patient with semaglutide. But once the patient is having evidence of decompensation and cirrhosis, usually the role will be no. So in the background of early fibrotic changes with this kind of metabolic syndrome scenarios, is still a well-advised molecule right now in order to improve resolution of steatohepatitis without worsening of fibrosis, fibrotic improvement without worsening of steatohepatitis. This has been well proven with your Essence trial and is still going on for the duration of almost around 240 weeks, which is happening. But so what are the various factors such as liver parameters? These are all the questions. Oh, so already I think most of the questions we have been addressed here, like all the metabolic picture we need to take into account, your FibroScan scoring, your NAFLD scoring system, and all these things will be having a strong assessment of your clinical point of your cardiovascular risk, whether it is there or not. Would you consider prescribing semaglutide? Definitely yes, when the patient, but normal BMI MASH is still a questionable issue. We need to be very careful. If the BMI, if it is not, tends to be in the higher side, or if the patient has lean NASH, you need to be cautious when you're going to use this molecule. But in background of MASH, obesity with significant weight reduction or some the appropriate duration. So we need to titrate. Once a patient, if you're going to stop the treatment in between, that is high risk of the patient to have worsening of events again. But that's what you need to titrate the doses slower, escalating the regimen 0.25, 0.5, followed by 1 and 1.4. So slow titration of regimen up to 2.4 you can consider, and slow tapering once a patient has a response. But you should be cautious to at least you need to maintain a dose of around 1.7 to have a significant potential response. That is what most of the guidelines they've been mentioned. Continue treatment for liver-related benefits beyond weight control, definitely yes, because it will be having additional beneficial role for alcohol craving efficacy. And apart from that, even in MET ALD, which means metabolic associated liver along with alcohol coexisting parameter, even in that kind of scenario, there is some potential role to prevent alcohol craving, which means, and along with that, the patient may have seen additional worsening of clinical improvement of events being reported when you're going to use even in the background of MET ALD, which means the alcohol consumption, if it is tends to be in the lower side. So why I would like to point out this, if the patient has metabolic syndrome in the background of fibrotic changes, obesity, the best kind of molecule now to consider your semaglutide. But if the patient has F3 to F4 worsening of fibrosis and more morbid obesity, which means the BMI, if it tends to be more than 3-5 like that, which means the still higher chances of response with your tirzepatide when compared to your semaglutide, which has been proven. And very importantly, semaglutide is having some adverse events being reported. For example, the most common adverse events with your Essence trial being reported with predominant by your GA-related events. And there are some contraindications. You should remember that the contraindications, if the patient is having suspicion of multiple endocrine neoplasia like presentation type 2, or if the patient is having evidence of significant gallstone disorder, or if the patient is having prolonged gastric already in the background of multiple clinical picture, if the patient is too fragile, if the patient is having optic neuropathy changes, or if the patient is having other presentations, you need to be cautious. To this kind of background, there are some contraindications to consider. Even there are papers to report that if the patient has significant severe depression, you should not use semaglutide to that kind of patient. So adverse events, there are rare events like your optic neuropathy, into whom your posterior ciliary arteries, if it is going to get involved in that. There are some rare adverse events being reported with your semaglutide being there, which is being less than 0.5% of the population as of now. Pancreatitis is still a challenging task with your GLP agonist, but will be less than 0.5% cases of being there. But usually, if you are going to address all the major parameters, slow titration, we can able to overcome the clinical risk versus benefit ratio will be always in the higher side with your semaglutide when you're going to use this molecule for a duration of time. So, and already been discussed with these papers, the MASH, fibrotic regression, all these things will be having a significant potential role. And in MASH management without obesity, including lean MASH, always the best line of molecule to be considered with your saraglide rather than your semaglutide in the initial phase. And how are you going to address this problem? Nowadays, there is a challenging entity. There is a phase, what is called as Ozempic phases, which is being new area to address this. Because once a patient, you are going to use this semaglutide for a duration of time, there is a risk for the patient to go for evidence of sarcopenic changes. That is why the major new molecules are being tried in the field to control that. So how are you going to address this scenario? Because there are so many indices, so many markers are there, then so many investigations, clinical assessment scoring scales are there, in which hand grip strength, your densitometer assessment, all those things you can take into account to see whether the patient, and how are you going to improve? Mainly, you should not make the patient to take to escalate the dose in a rapid phase. That's very, very important. And frequent small dosing meals you need to consider if you are going to use this presentation. And protein subjective, you need to give at least 1 to 1.2 grams per kg per day of proteins to be subject to the patient in an effective way. Along with that, BCA supplementation, if you want, you can add on to the patient. Apart from that, you need to maintain a strong resistant training at least 2 to 3 days in a week, and aerobic training, at least you need to maintain a proper exercising at least 2 to 3 days in a week to be considered when you want to improve this kind of clinical scenario occur to prevent the patient to land up with evidence of a loss of fat, subcutaneous fat, if it is going to get blistered. This is what the entirely new terminology being addressed, nothing but the Ozempic phases being reported nowadays. This is a new challenge to address when you're going to use this molecule, what's called as semaglutide. It's still a challenging task. But apart from that, when you're going to look for the risk versus benefit, slow titration, all those things, definitely we can able to improve the clinical scenario reasonably well with your semaglutide. And mainly for your obesity, which means the weight reduction guidelines 14, 9, 16, as per the trials what's mentioned is step trials, which means the significant body weight reduction being proven with that. So very importantly, before concluding, what I would like to say here is the dosage when you're going to use should be well titrated, max up to 2.4 for a duration of time every weekly. You should not be in a hurry to escalate the dose and start with 0.25, 0.5 slow titration every 4 weekly. We need to maintain, followed by the clinical picture you need to see into an account and make sure that the patient should not land up with evidence of a protein trial, a worsening of your protein metabolism, or make sure that the patient should not have evidence of sarcopenic changes. And clinical recognition is very important, but isolated semaglutide alone, most of the time, no. We may need to consider other molecules. Sometimes there are papers you look for your semaglutide with resmetirom to be considered, semaglutide with saroglitazole. There is a paper to have a beneficial role. So based upon the clinical scenario, we need to address such molecules along with add-on therapy to your semaglutide to prevent the progression of your fatty liver to fibrotic changes, your MASLD to prevent to augment for the fibrotic changes and other things to happen. So very importantly, we need to make sure that whenever you're going to choose a molecule, clinical scenario of the patient should be promptly recorded. That is very important. We should not miss. And head to food examination, proper screening and surveillance, pancreatic assessment, ophthalmic screening, all this picture we should not forget before you are going to subject the patient with your semaglutide and other things. So this is what the major indices I would like to address here. And these are all the various parameters that they have been mentioned. So the very important, the real world challenges in India is the cost constraint. It's difficult task. We cannot able to establish well with most of the population. Most of the remote population still a challenge. Risk of adverse events because the gastric emptying, the patient may have more nausea and other things. That's why we have been recommending to start the patient with very, very lower dose. And this is still a challenging task. And to whom we are going to choose, how to screen the population, how significantly it's being established in Indian scenario. It's still a challenging task. FibroScan, is it well available everywhere? No. It's if you're going to do in a well good center, the cost of FibroScan will be going almost around 10,000 rupees. It's not that easy for most of the population to afford. So to whom you are going to subject? All the fatty liver you're going to subject for FibroScan? No. So this is what the clinical problematic indices you need to choose. You need to identify the metabolic syndrome in a prompt way. But what are the things, what are the molecules we should not address, we should not forget to address an important thing. The diet, lifestyle, you need to maintain exercising at least around 45 minutes per day, at least for 3 to 5 days in a week, followed by resistance training at least for around 20 to 30 minutes per day. All this picture you need to address if you want to overcome this kind of clinical presentation effectively. With this, I would like to rest my presentation and thanking you all for patient listening. And if any questions is there, I'm happy to take on.
Yeah, sir, thank you so much for this wonderful presentation. Sir, can we wait for a few seconds if attendants have any question?
Yes.
Sir, I think there is no question. Your presentation has covered all the queries from attendings. So with your permission, can we end this meeting?
Thank you very much, Team Lupins, and thank you very much for all the audience for being here. And control the fatty liver effectively, screen most of the population for fatty liver, and if the patient have evidence of fatty liver, never miss anything. With this, I'm happy to conclude. Thank you very much.
Sir, thank you so much for your insightful knowledge and valuable time. Thank you all the delegates for joining today's session. So with that, we are closing this link. Thank you.
Thank you.